Welcome to Airbus Helicopters and to this very special live exchange, sharing HEMS best practices to face the COVID pandemic.
We have seen that our customers operated with a mix of platforms by respecting maximum safety measures. At the beginning, HEMS operation drastically decreased due to the lockdown periods. Animals took over the city. No cars, no roads, no people out means fewer accidents and as a result, less flight hours for the operators. Safety first. Under that ultimate goal, mature operators updated and adjusted their existing procedures. Safety first. For all operations, infection of crew members had to be avoided at all costs. Medical teams were approaching possible infected patients with special PPE, special mask, face shield, but also gloves, protective gowns and eye protection. SOP for the use and disposal have to be in place and trained properly. The patients received a mask immediately on scene, and some operators transported infected patients only with intubation and therefore HEPA filter in place. Pilots were no longer supporting the loading, unloading of patients and tried to avoid contact as much as possible. But let's hear further details directly from our customers.
Norwegian Air Ambulance, or NOLAS, as many of you know us as, is the sole HEMS operator in Norway and Denmark. And as such, of course, we have been affected by the pandemic. Our 17 HEMS bases, operated 24/7, are very different from one another, both from an operational standpoint and as far as the medical profile is concerned. The base in Kirkenes, just 4 kilometers from the Russian border, at almost 70 degrees north, is very different from the bases in Oslo and Copenhagen. With the population being 1,000 times smaller, it is not the severity of the average patient that is our biggest challenge in Kirkenes. The 800 kilometers to the university hospital, the weather, the cold and the darkness is, however, very common challenges up there.
Yeah, saving people's lives. That is our mission. For over 4 decades, we have been committed to nationwide, around-the-clock air rescue. Innovation drives us so that tomorrow we can save people whom we couldn't help today. And a lot has changed in these times. However, a situation like the one we have experienced now has never existed before. The worldwide corona pandemic affects us as an organization on different levels. First of all, let's take a look on the changes in our deployment volume. Overall, the number of missions was around 5% less than those of 2018 and 2019. Performed more than 300 special missions in direct connection with the COVID-19 in the first half year. And the sad highlight, I have to say this, was the month of April when our crews undertook 166 missions with patients infected by COVID.
Well, first of all, I'm sitting here in front of this camera to talk about our response to the emergency, but I'm not the hero of this emergency response. Babcock is a mission critical service company and we are used to working in a critical situation, but what happened during the outbreak was beyond any pre-planned plan that we could eventually have. We are trusted by government because we take care of firefighting, emergency medical services, main MRO for military activities, nuclear, navy, land, but this was out of the ordinary. We operate more than 35 years in the medical services. We fly 83,000 missions per year and we employ more than 1,000 medicals worldwide. But the outbreak was something incredible. And we have been learning and understanding and develop a plan on how to respond. And we transfer immediately with our organization all the lessons learned from this country, from this region, everywhere in our nations where we operate. There are nine different nations.
What does Rega? Rega does what we usually do. We provide people in distress with quality care by air, nationwide, fast, day and night. And we do that since 6 to 8 years. And this Swiss non-profit foundation of 440 dedicated experts try to create added value to our patients' lives with and without COVID, and also to the Swiss health system. So we are funded and supported by 3.5 million patrons every year, and Rega operates 18 HEMS helicopters, 3 super mid-sized jets, and its own mission control center, as well as own aviation infrastructure, like a nationwide radio network, a nationwide flight weather network, IFR procedures, and 12 helicopter bases.
Gentlemen, thank you all for these valuable insights. COVID was certainly a big factor in operations over the past few months.
We here at Airbus saw an increased number of queries to our experts starting in February, centering around airflow disinfection, cockpit separation, and patient isolation devices. First questions were raised about the airflow in our platforms. Airbus quickly issued a so-called information notice describing the airflow management. A constant airflow from cockpit to cabin seems preferred, prevents the virus to travel to the front. Heating and air conditioning operation should be avoided as much as possible due to air circulation. Airbus issued another information notice quickly and briefed about all possible supplies to clean and disinfect the helicopter. Among those, the use of ultraviolet UV lamps have been discussed since the beginning. Some operators have started tests already, but first feedback received shows a negative impact to material and in particular to windshields. We therefore do not recommend such device at the moment, but will monitor and follow the feedback closely. I would like to mention the air cleaner, a black box that includes a UV light. The air in the cabin can pass through that box with ventilation and reduce the amount of pathogens in the cabin air. A physical separation between cockpit and cabin seems to be efficient. Our engineers started very soon and worked out an EASA-approved STC, a minor change approval sheet. The material is available everywhere, and with the installation description, our customers could install that solution timely around the world. The IN is available now for nearly all helicopter types of Airbus. The use of patient isolation devices, PID, that can provide the ultimate protection for the medical and flight crews. I want to share with you some systems which are used today around the world. We have solutions on the H125, here from Brazil. And of course on the H135, we see here from Securotech France and also from AAT in Austria. Some even more sophisticated systems are those from ISOARC from Israel, as well as high-end solution called EpiShuttle, as seen here by the DRF Luftrettung in Germany. A special solution has been designed in France by the emergency hospital in Dijon and our operator Babcock. Local approval could be necessary, and this is where Airbus steps in and provides engineering support up to so-called non-technical objective statements. I would say for all of us, you can count on our support, of course, also in the future.
The upper left photo was taken during my mission in Sierra Leone, already in 2015, when we repatriated an Ebola patient. The other photos were taken during COVID missions in 2020. So what do you think is the difference in transporting an Ebola patient, a tuberculosis patient, or a COVID patient? Certainly, the risks associated with Ebola are by far greater than those with tuberculosis or COVID-19. But after all, we talk about HEMS transports of infectious patients. This is a very part of Rega's humanitarian DNA, and we have been prepared for and conducted such transports since decades. So how do we protect the crews from the patients and vice versa? First, any C-19, any COVID-19 patient or suspicious patient gets a surgical mask, if not already intubated by the hospital. Then the patient will be wrapped in all weather blankets to reduce a potential contamination with the patient's clothes. And all that is done by medical crew wearing PPE, personal protecting equipment. That means gloves, goggles, appropriate masks, coats, gowns, and the medical crew adhere also to clearly defined SOPs. For instance, handling of syringe pumps, additional COVID bin bags in the aircraft, disinfection procedures, etc. Rega's operation motto also in these transports is mission first, safety always. Rega's crews, medical and flight crews have not been harmed or infected since the beginning of the pandemic by applying our medical COVID operation concept. This proves and confirms our medical transport concept based on the continuous medical safety risk assessment process as a part of the overall SMS. A different operator will come here to a different result. As always, when SOPs are just copied but not adapted to the overall operational, medical and aviation aspects. I really strongly encourage you to conduct such a safety risk assessment for your own operation. We have been able in the past to build up and demonstrate considerable experience in transporting infectious patients since decades. We paid great attention to recapitulate and to intensify these experiences, as well as to integrate them into the transport process and train the crews. Then the risk awareness of our crews was another aspect. The goal, as always in risk management, is to identify the hazards and to mitigate them. What you see here is the basic hazards in terms of a potential infection. For transports of COVID patients or suspicious cases, the goal is to prevent the transmission of a virus load that could infect our crews or contaminate the aircraft. This means practically that the patient gets a surgical mask already from the very first contact. An exemption from that would be intubated patients. Here we talk about a closed airway with filters that is in place. In addition, the patient will then be wrapped in all weather blankets to prevent contaminations from the clothes. Besides the regular personal protection equipment, the crews wear additional masks. Can we get further, please? Surgical mask or FFP2 masks, goggles, and a coat. Moreover, we have introduced a variety of SOPs to avoid additional exposure of the crews and aircraft for potential COVID virus hazard. So we have reduced the pickups of patients in hospitals and expect to meet them at the airport or the helipad. Then the disinfection procedure clearly defined, and also a so-called COVID bin bag is used to store potentially contaminated consumables, etc., safely in the helicopter during the flight. Or, for example, we use also our own drug pumps and syringes to prevent any potential contamination. As you see, we have introduced safety barriers in terms of additional COVID-19 specific standards or operating procedures. More than 400 successfully transported patients, COVID patients, with a magnitude in number of dark cases, prove, confirm, and testify from a solid empirical base. The concept works absolutely safely for Rega's crews and patients. Flexible working hours, telework, administrative SOPs, that means rules for meetings, but also for our own cantina, for visitors and upcoming illness symptoms of the staff, have positively contributed to the resilience of our operation. So thank you for your interest in Rega's COVID operations, which is, as already stated in the beginning, just a specified, but nonetheless still a regular HEMS mission.
Earlier in the conversation, you meant that you had to deal a lot with the unknown. Can you give us a bit more insight?
Normally, our operations are performed according to SOPs that are thoroughly developed based on 40 years of experience and solid scientific data. In March, suddenly we had to make a lot of decisions based on very limited knowledge. This put our management in a crisis manage mode for a long time to answer many questions like how to protect our crews on duty, what is the right level of PPE, How do we clean the aircraft and the equipment? How many crews will we have infected and how many do we have to put in quarantine? What about the pilots that live in Sweden or France? How do we cooperate with all the different health trusts that we cooperate with in daily business? As a HEMS operator, we faced a number of unknowns, and mid-March was the start of a continuous adaptation to changing needs, knowledge, and regulations. The first questions we had to answer was how to keep our crews safe and how to protect our operational capability. Short term, it was a question of having enough pilots, HEMS TCs, and doctors. But the technical base actually was the first exposure to infected employees and massive quarantine. We saw a real potential risk that infection and quarantine among our technical staff would reduce our technical capability to critical levels. Therefore, we started to make plans to separate the employees so that everyone would not be near contacts to everyone else in case of infection. And practically, we did this by separating the technicians working online with the technicians working base maintenance. In addition to that, we implemented a lot of the measures that we have all become so acquainted with this year, like keeping a distance, wash your hands, use alcohol, externally that is, and no more buffet lunches. To keep our operational crews available, the most obvious thing we had to do was avoid exposure on duty. What is the appropriate level of personal protective equipment or PPE? Was it the EpiShuttle or is it a simple face mask? Dependable science was not available, so it was a risk assessment with very limited data input. To protect our crews from the threat of all patients with unknown COVID status, new procedures were established. The medical responsibility at our bases lies with the local hospital or health trust. And since it was a lot of humans making their risk assessment based on limited knowledge, limited science, the resulting procedures become quite different. And they were constantly changed due to incidents and new knowledge. Following these differences and changes has been one of our biggest challenges. What to do when we were told that a patient was positive after a transport? How do we disinfect the aircraft? Do we consider the crew close contacts? Among other supportive companies, Airbus has been able to provide guidance in a timely manner, and that has been really helpful for us to adapt to these changing needs. Our chief doctor, Professor Solid, suddenly became very busy being head of infectious control. In our three-crew concept, all crew members are involved in the entire mission. This means that when workload permits, the pilot is a natural assistant during medical treatment on ground. To avoid exposure, it was decided that the pilot would stay minimum 2 meters upwind from the patient with all the equipment that we were not using. We have managed to keep our staff safe. Only one pilot infected during travel that tested positive after getting symptoms on duty. The base was closed down, operations, and the base was cleaned. Operations commenced the next day with a new crew. The HEMS TC and the doctor that lived on the base with the infected pilot was not infected. We took that as proof of our new learned behavior is limiting risk and that we have to refrain from our greatly missed hugs and handshakes for a few more months.
I will briefly outline some practical components that have helped us to maintain our commitment. Mainly, I will have a look on the supply chain, the protection of employees, protection of our patients, and as well as additional operational challenges which we went through. In March, the topic of inventory of FFP2 masks was particularly important, a simple thing, to be clear. And also our long-standing suppliers were able to supply us sufficiently. Stocks were extremely low. Not knowing how the situation would develop overall, and especially in Germany, we searched worldwide for further suitable suppliers to solve this issue. Another important question was, how do we protect our employees? How do we avoid closures of sites or our maintenance base. And as I said, it went well. And in some areas it was easy. As far the administration was concerned, the answer was clear: home office for all. For the technicians in the maintenance hangar, we introduced shift work. A much bigger point is how to make sure that our crews will not be infected. And Stefan already mentioned this, and also Erik from Norway mentioned this. This was for sure a challenge. How high is the potential risk from released droplets by infectious patient for them was the main question. And back in autumn 2019, we addressed this topic and started the first scientifically accompanied field test. So generally speaking, the test indicated that with a spontaneous breathing patient, there is a risk of pathogens not only spreading in the cabin, but also in the cockpit. So at the beginning of the pandemic, we therefore introduced completely new equipment to stop the spread of droplets, or the risk, let's say. The so-called Epi-Shuttle, a specialty isolated patient stretcher. Since 2003, we have been intensively engaged in research into such isolation units, and that's now what we decided. Without the Epi-Shuttle, crews have to disinfect the interior on an aircraft in particular complex way after transporting a patient with high infectious disease such as COVID-19. So the Epi-Shuttle represents an important element, but it's not the element. It's one among others, and it should help patients with a specific medical situation. For this reason, 11 of these Epi-Shuttles were equipped to the helicopters, and it was only to secure our crew, but also to secure the patients which were transported. Because if they go this way, they are normally also in a situation which is not a good one. To ensure an optimal mount for the stretchers, the EASA Part 21 design organization at DRF developed a multifunctional ground plate. I have to admit it was done really directly during the crisis, during the pandemic. And thanks to the special ground plate, the stretchers can be fastened perfectly in a very fast way in the helicopter. Once regular service operations were ensured, we asked ourselves how could we contribute stabilizing the health system in general. To this end, Christoph 111, an intensive care helicopter, additionally stationed at the Karlsruhe Baden Airport, went into service on the 28th of March. It was the first helicopter in Germany specially designed for intensive care transport during the pandemic. Within just 36 hours, our project team succeeded in organizing a suitable helicopter from our fleet, the medical equipment, the necessary infrastructure, as well as the initial crew. The offer was very quickly appreciated, especially for the transport of patients out from hospitals in hotspots like in France or in Austria. Our concepts have shown their value. The protective equipment is adequate and helps us ensure safe transport. And yet it was already said by Stefan Becker from Rega, one thing should not confuse us. The hygiene regulation for transport have not changed. Wherever it is the flu or COVID-19. Rather, the boundary conditions have changed. Cases of flu do not lead, as an example, to the closure of a maintenance center. However, the quarantine regulations in Germany for COVID-19 could. All in all, I'm proud to say that we as an organization have stood our ground in the face of many challenges now. This is partly thanks to our considerable experience, the fact that we have constantly developed ourselves, as well as the topic of air rescue in general. The willingness of our staff to cope with the limitations and many challenges at last, and last but not least, the help and cooperation of every person with the aim of saving as many lives as possible.
Babcock is a global operator, and we had to face this as a global, with a global response. At the very beginning, we realized, for instance, that the PPE availability was in danger. The Italy and all the other countries were starting a requisition campaign where it was almost impossible to find PPEs to provide the protection for our people that was in front line. What Babcock was a response, opening 2 distribution centers, one in the United Kingdom and one in Spain, where we have people working 24 hours on 24, 7 days on 7, in order to receive the PPEs, understand the needs all over our countries of operation, and deliver directly to the bases in order to have our people protected. We developed Babcock best practices based on what we thought were the best things to do, but taking into consideration the local regulation that daily were coming out from local government or health services. So we started developing the separations unit, the sanification process for the helicopter, isolation pods. As you have seen before, we have been developing isolation pods. There is with the Babcock TCO, where you can isolate the patient but still have the possibility to intervene, to connect the patient to the rest of the electromedical in the helicopter. That was very important to develop in one place and deliver in all the other places. We even gave as a present to another operator in UK some of this pod. This charity is not our customer, but they operate in a community that we serve, so we really care about the people in that area. This experience was extremely important. We're in Norway, in the city of Hammerfest, very up north in the country, that is 550 kilometers distance from the nearest hospital. There was a huge outbreak of COVID. We were able within hours to open up a base over there and start supporting the community in Hammerfest. But let me say that we in Babcock are very, very proud of our people that is been working and is still working day and night in order to support the community and defend the people.
Unfortunately, all good things come to an end, and now we've reached it. I think I can speak for all of us when I warmly extend our gratitude to all of our speakers, as well as the entire HEMS community online. You and your staff, despite risks to yourselves, relentlessly continue to keep us safe. Thanks to your efforts, many lives have been saved by your helicopters around the world. And we at Airbus Helicopter are proud to have participated and to have played our part in this fight against the COVID by keeping your machines flying. Goodbye to all and stay safe.
Goodbye, Alison.
Bye. Bye, everybody.
Goodbye.